So now I have the pleasure of introducing Dr. Strand. Dr. Strand is an Emeritus consultant in the Division of Speech-Language Pathology and the Department of Neurology at the Mayo Clinic. She's also an Emeritus professor at the Mayo College of Medicine. Her research has been conducted on developmental, acquired, and progressive apraxia of speech and issues related to intelligibility and comprehensibility in degenerative dysarthria. She's worked in multiple settings, including public schools, private practice, hospital, and clinic settings. So unlike many researchers who never understand what it's like in the clinical world, she has a foot in both worlds and really understands both. Her research and assessment and treatment of children and adults with speech and language and voice disorders has impacted all of us in this room. She's published many articles and chapters on speech and motor disorders, and I just want to highlight a few of her texts: Management of Speech and Voice in Degenerative Disease, Clinical Management of Motor Speech Disorders in Children and Adults, and Clinical Management of Motor Speech Disorders in Children. She's an ASHA Fellow and has received honors of the association. Just to add to that, it's been a pleasure in my career to get to know Dr. Strand. For me, I began as a clinician and now as a researcher. She's really a role model for those of us to understand how we can conduct our research with an important clinical focus, and there's such a need for that in our field today. So, Dr. Strand, it's all yours.
Thank you. Really nice introduction. Thank you. Can you all hear me okay? I'm going to move this way so we don't get feedback. I'm short. So I will walk around a lot, and I forgot to tell the video people, this is being videotaped today for the foundation. They wanted a copy of this. So I hope it's not going to be a problem that I walk around a little bit, but I have new boots and I want to show them off. But mostly, I don't like being on a stage because I like being closer to y'all and walking around and all because you're my colleagues. You're my peeps because I am a clinician, and I was a clinician for 9 years before I went back and did my PhD. Throughout my academic life at first the University of Vermont and then mostly at the University of Washington, I always focused my research in a clinical way and spent lots of time in the clinic with the students because that's where my first heart is. I'm a average to fairly good researcher. I'm a pretty good professor. But what I love and I think do best is be a clinician because that's why I got into this field. And I think that's why a lot of you did. Our goal, our passion in life is to help people who can't communicate do that better. And how noble and wonderful is that? We all have stories of where we've changed someone's life. We get to do that. But what we do is really hard. It's really hard because we have to know a lot of stuff about a lot of things. And we don't really have time in a 2-year program to learn all that, right? So how many of you have ever sat across the table from a child who has very little speech and you think, I'm not sure? Of course, every single one of us. I was very fortunate for the last 16 years to be a full-time clinician again at the Mayo Clinic. I was a professor in the medical school, but when you work in a medical school, the medical school, first 2 years of medical school, you are in classes a lot. And so I was only involved in the neurologic part. You know, they have a neuro block, and I would give several lectures there. Most of my teaching in the medical school was with residents, and the neurology residents, the pediatric neurology residents, and the pediatric residents. And so we would do lectures for coursework that they did, but it's always, that coursework was 4:30 to 6, because they saw patients all day. And we saw patients all day. So I saw patients all day, every day. And most of the teaching we do with residents is they do rotations with us and see patients with us. So I know what you deal with. I would show up at 7 o'clock to review the hospital list before I went and did hospital rounds till 10, all assessment. And then I would come back and I would have patients every hour until 5, which of course always went to 5:30. But at lunch, there was grand rounds and billing to do. So at 6 or so, I could actually start dictating because I couldn't get to everybody during the day. So my days were typically 7 to 7. So this kind of work in my research was on the weekends. So all of that is only to say that, well, it's actually just told you that my life was totally out of balance. So that wasn't such a good thing to admit. But what I want you to understand is that we are colleagues. I know what it's like to have more patients in a day than you feel you can do a good job with. I know what it's like to not be sure. We saw both adults and kids at Mayo, all with very difficult neurologic problems. Most people came to Mayo when they couldn't get answers elsewhere. So what we did was hard. There wasn't a day that went by that I wasn't sure. So this foundation, the Once Upon a Time Foundation, came to fund activities, many activities actually, these workshops are some of them, to help speech pathologists know more about assessing and treating children with pediatric neurologic problems. And it came about because the benefactor had a child with a motor speech disorder. And he went to a number of clinicians, and the child had been in therapy for a few years and still had no speech. And when he came to Mayo, he got answers. We were able to explain it all and put them on a program of treatment that worked very well, and now she's a very intelligible talker. He was grateful for that. He felt that his question to me was, why can't every therapist I go to do this? I said, well, we don't teach it in our universities. And by and large, you have someone here at NYU who specializes in motor speech, but around the country, that's very rare. And most people get one lecture in pediatric motor speech as part of their adult neuro class. That's the norm. And we wonder why we're not sure. So I'm saying all of this to sort of get it out there that, of course you don't know. Of course you're not sure. Think of how many hours you spent studying phonology and approaches to treating phonology, and how many hours you got in learning real theories of speech motor control and why certain treatments might work better than others. And how many hours did you spend listening to vowel distortions so you could distinguish them when you saw a child in front of you and you were trying to figure out, is this a motor problem or not? No wonder we're not sure. So the Once Upon a Time Foundation is focusing a lot of their support on, in a number of ways, to help speech pathologists get this education that we don't yet provide in our programs. So that's why I'm here today, and I hope I've given you some validation that I do what you do. And so a lot of what I'll be talking about has come from my experience, as well as the literature. And I need people in the front row to help me out today. I get excited. I love this stuff, and I have a passion for these kids. And I'm afraid I'm going to walk right off this stage. So if I get anywhere near here, I need you all to go. Promise? Okay, let me see. Let me practice. Okay, excellent. Thank you. All right. So we have to start with disclosures because that's what we do. I am on the advisory board for CASANA, Childhood Apraxia Speech Association of North America. That's an unpaid position. And then financially, I receive royalties from ProEd and TEMA. However, these books are getting older now, and I could probably buy you guys a Starbucks with what I get in a year. And the Once Upon a Time Foundation is paying me a stipend for presenting this course. Okay, here's the other thing. At Mayo, I was a generalist. So is Joe Duffy. We all are generalists at Mayo. And although Joe and I do mostly differential diagnosis, we do everything. So I saw children and adults with every kind of conceivable problem. I did Botox clinic. I did ALS clinic. I did VPI clinic. I did cleft palate clinic. So you can imagine, even though my area is motor speech disorders, I had to go to workshops like this to tool up and what's newest in cleft palate clinic work, And I would go and sit for 3 days with Ann Kummer, and my head would be like exploding, and I'd have a notebook this thick, and I'd go home, and it was very, very hard to implement what I had just learned. And why is that? We're busy. It takes effort and time to implement something new. As I've been doing these workshops, it's become clearer and clearer to me that we're missing the boat here, because we're all investing a lot of time and effort. And if it doesn't really change what you do, why are we doing this, right? So we're going to be adding some implementation science research to these workshops. We're not doing it for this one. But I'm gonna start off begging you, and then give you some ways to do this. Begging you, as a result of this workshop, that you do at least one thing differently. That you make a goal and a promise to yourself, and it's not really just a promise to yourself, it's a promise for those kids you're not sure about. That you do something different, at least one thing different. And as we go through, I'm going to say, this would be one of the things, if you're going to pick one. So I want to have that in your head, and we'll start, actually, by talking about the most important points I'd like you to take away today. And the ones that are in bold are the most important, in my view. So first of all, and this comes from my work at Mayo, where I would get phone call after phone call after phone call from parents all over the United States, and sometimes Europe, saying, and I'll give you a story about this later, my child has just been diagnosed with apraxia of speech. They'd be frantic. Does this mean he needs surgery? And it's because the speech pathologist felt like they either couldn't explain what this really was, or let the parent just believe that this was a medical diagnosis. Sometimes I've had people at workshops raise their hand and say, my principal, the principal, won't let me use that term because it's a medical diagnosis. Apraxia of speech, that term was made up by Fred Darley in 1969 in a paper in Paris to denote adult apraxia of speech as a disorder different from aphasia and different from dysarthria. It's not a medical diagnosis. The medical diagnosis would be the stroke, the actual neural necrosis that results from a stroke. The speech behavior, the speech diagnosis, is apraxia of speech. And the same is true for childhood apraxia of speech. Yoss and Darley coined this, although Muriel Morley in the 50s used the term articulatory dyspraxia. So this has been used for many, many years to denote a particular type of speech problem. It's not best diagnosed by a physician. I taught the residents at the Mayo Clinic everything they know, which is very little because we had very little time to spend with them, what they know about childhood apraxia of speech. And most medical schools don't have a speech pathologist on their faculty. So I can tell you that most physicians, pediatricians and pediatric neurologists, don't really know the nature of this disorder. It is not a medical diagnosis. It's a label for a speech disorder. Sometimes it happens because of a medical diagnosis, like a neonatal stroke or a head injury or some other cerebellar problem, perhaps. However, we have to disambiguate that medical diagnosis from the resulting signs and symptoms. We're going to talk about diagnosis, differential diagnosis, but we're talking about the speech diagnosis. And when you're talking to a parent, it's very important that you make this clear to parents when you're talking to them about your differential diagnosis. Now, we know it always occurs along with phonologic delay and typically expressive language problems. But when we use the word praxis or apraxia of speech or dyspraxia, we're talking about a motor speech impairment. Okay, this is probably the most important thing I'll say today, number 3. This is a paradigmatic shift from what we learn in school and what we typically do, how we typically think, and how we typically talk. But for children that really have significant difficulties with praxis for speech, planning and programming movement, the focus of treatment, and actually the focus of what we're observing in assessment as well, has to be on the movement versus the sound. What do I mean by that? Well, think about how we talk. We're going to work on our sounds. Think about our goals. I'm going to work on fronting. Think about I'm going to work on F, I'm going to work on R, I'm going to work on this sound. I want you to think a moment about what happens, and I'll talk more about this today. I'm focusing more on the things that people tend not to understand the first time, and I'm going to skip over other things more quickly. I change these up a little bit every time, trying to get the perfect mix, which of course will never happen. I want you to watch me. Can you all see me okay? That light's in my eyes, so I can't see you very well. So when we talk about, let's say the word boy, if we think about it, we're going to work on the bilabial voice plosive, ba, and we're going to work on oi, right? Okay, so we think about it, we might go ba, oi, and we might think that makes it easier for the child. But watch what we're really, when I say the focus is on the movement, this is your target. But you have to watch me because I'm going to take out the voice. That is the target. The unsegmented movement gesture at the level of the syllable. We don't segment movement within a syllable when we're talking, ever. So I'm going to bring this up 3 or 4 times throughout the workshop. I have spoken, and I always tell this story, so you've heard this before, for 2 whole days sometimes, where I talk about the movement being the important thing. Now again, this is just for the kids that have apraxia. It's not for most kids. It's for those 5% of speech disorder kids that have some specific difficulty with praxis that contributes to their speech sound disorder, where this becomes very important. But I spent 2 days talking about this, you know, back and forth, and at the very end, the first question is, well, which sound do you usually start with? Well, number 1, wouldn't that depend on the kid, on the child? And number 2, I thought I should stop at that point because clearly I was terrible at this. This is huge. This is a paradigmatic shift, and that question points out how deeply ingrained that is in us. It's easier for people like me that are old because phonology didn't exist when we were in school. Seriously, there were no books on phonology. There were no articles. That wasn't even a concept yet. I'm not that old, but that's the truth. And so when phonologic theory came along, the pendulum really shifted there. But we've got to come back for this small group of kids to think about the fact that the focus of treatment is the movement. And I'll spend this afternoon talking about how do we do that. One of the things we're going to do is create specific stimuli based on vowel content primarily and also syllable shape during early treatment. We're going to incorporate the principles of motor learning, which I'll talk about at some length today, using fewer stimuli as the child is more severe and using more dynamic shaping of the movement itself, of that gestural movement within the syllable. This one's bolded because this is one of those things, if you change nothing else about what we talk about today and you maximize the number of response trials per session, you will see quicker, more efficacious and more efficient results. I'll be talking about that at length. Remember, if they're in bold, I really want you to take these points away. I'm going to be talking to you about how I'm going to commit some blasphemy here and say, I don't have any pictures or games on the table when I work with these kids. Ever. Now, these are the kids with severe praxis problems. From the nonverbal kids to the unintelligible kids. Don't do it. Because when we have their attention focused on a picture or spinning a thing when they're trying to do the game, not only does it take more time, but you're missing out on the most probably the most facilitative cue we can give, which is attention to our face. And we've known this, those of us who work clinically, for years, how important that was, but didn't have a really good explanation until the research came out in mirror neurons, which helps us understand that a lot more now. So we'll talk about that. I'm going to talk about a number of principles of motor learning, including using a modified block approach, moving to more random as the utterance becomes more accurate. I'm going to talk about the importance of using very specific feedback, like close your mouth a little, ooh, too tight, oh, not so big, whatever, versus just good, or not quite. That's another principle of motor learning that we'll talk about. We won't have time today, I forgot to take this off, to talk about probe testing, but I do want to tell you right now, you don't want to take up your precious therapy time doing therapy data, and the techniques I'll be talking to you about do not allow you can't divide your attention that much, or you're missing out on a lot of the ability to shape the movement accuracy in order to help build their motor planning and programming processing. Now, again, this is just introductory. I'm going to talk about all this stuff in some detail. So we talk about probe data, which means you choose an interval and you probe how they're doing in a certain context. Just make sure you do the same thing every time. And that's a much better way to keep track of your progress, because you just don't have time in therapy. And for sure, this maybe is one of my pet peeves. So allow me to talk to you about it. You want to make sure you have a rationale for every clinical decision you make, and be confident in your ability to explain that rationale to parents and to colleagues and to anyone who might be involved with that child. This is the hard part, isn't it? Sometimes we do things because we heard about them. Sometimes we do things because we took a workshop. In this workshop, I'm going to talk a lot about why we do everything that I might suggest for certain children. And for those who's coming tomorrow, so a lot of you coming tomorrow, we're going to actually practice thinking through and either writing or saying out loud this rationale, because it doesn't come easy if we're not used to doing it. This is hard. But in my view, this is everything. If you can't explain, if you can't come to a rationale and explain it, then maybe your clinical thinking isn't where it needs to be to work with these really, I think, kind of difficult cases. All right, so that's the whole workshop. So we're going to start. The benefactor had asked that I do these series of workshops, particularly, he wanted me to just do DTTC. I said, I don't want to do that for many, many reasons. One of them is DTTC might be appropriate for the very severe kids, but it's not going to be appropriate for everybody, number one. Number two, that makes us technicians. If we just go to a prompt workshop or a DTTC workshop or whatever, and we just learn how to do the technique, because that's all these programs, any of these methods are just a collection of cueing techniques. That's all they are. And if all you do is say, well, I can do this, and I can do DTTC, and I can do rest, and I can do prompt, you could be great at all of them. But if you don't make all these critical clinical decisions appropriately that you have to make, what are your stimuli and why? How many are you going to work on and why? How am I going to organize practice within the session and why? That's the nitty-gritty of being a clinician. If it were just knowing how to do the shaping with DTTC or the prompts with prompt, well, we'd just be technicians. But we're not. We're called clinicians for a reason. And I'm going to spend a lot of time today talking about these decisions that make us clinicians. They're hard. It's scary to jump in. But today I'm going to do something a little different later today, and we're going to talk about giving ourselves a little opportunity to do this one little piece at a time until it becomes more natural, because it's hard at first to do something different. How many of you are in the public schools? So that adds a whole nother layer of complication, because you guys are really my heroes, because I left the public schools after a few years. Because in my mind, the service delivery model that has been sort of developed and created for the public schools works probably pretty well for language and literacy, but not so well for speech problems, and really poorly for severe speech problems. And that's just the way it is. So those of you that are going to be sitting here today listening to all this are going to be thinking all day, oh my God, how am I going to do this in my setting? And I get it. I've been there. And I still kind of consult there. I know exactly what you're dealing. I read, for 16 years at Mayo, I read IEP after IEP after IEP from all over the country. You're forced to write things down that don't relate to the kind of thinking that we really should be doing. I get that. What I want to encourage you to do today is to do what you have to do for whatever setting you're in, because we have to. And then, for that child sitting across that table, you keep your own little file where you do what's going to be conducive to your clinical thinking. And we'll get examples of that today as we talk about coming up with diagnostic statements that help clarify our clinical thinking about differential diagnosis. And also, how do you in our head, in our clinical thinking head, how do we set goals down that might be very different from a behavioral objective that we have to put in an IEP? They're very different things. No, the benefactor asked me to talk mostly on DTTC. We're going to have to start with a brief review of differential diagnosis, because that is what we do as we start our treatment planning. So we're really starting treatment the minute that child walks in the door. Because if we don't plan treatment appropriately, right, then we're not going to be doing treatment appropriately. So we're going to talk a little bit about distinguishing those children with respect to the relative contribution of phonologic impairment, CAS, and or dysarthria. That is a linguistically based problem like phonology versus a more motorically based. And here's what makes it even harder. What's the hardest part of this? They don't come in one flavor, do they? Almost all of these kids have a combination of all of it. Of course they do. So that the important word there is this relative contribution. Are they having a lot of trouble learning phonology because their motor impairment undermines their ability to practice early babbling to get to the point where they can develop, their phonologic skill? Or do they have mostly a phonologic problem, but they're one of those kids that just has some mild motoric things that are just getting in the way? How do we treat that? Well, it's going to be different than the child with severe CAS, but in both cases, we're going to be implementing the principles of motor learning. Because for kids that have problems with Praxis, we have to help their brains develop that motor planning and programming processing to be more efficient. And we're going to talk how to do that. So what do I mean by this Praxis thing? Well, Praxis deficits, if you just look it up in a dictionary or a medical book, are really deficits in the ability to conceptualize and to plan and to program skilled volitional movement, and I'll talk about what we mean by that more specifically. It might be caused by some determined problem like a neonatal stroke or anoxia or something, but more often it's undetermined. That is, we can do MRIs and we don't see any problem. There's nothing in their medical history to indicate why that might happen, but we know from observing the child that's something related to either the proprioceptive afferent information, that proprioceptive input that we need to plan movement is awry, or the pathways leading to the motor planning area, or the internal and external circuits of the cerebellum and the basal ganglia, which are very complicated, but likely involved in this disorder. We don't really know yet. So in my kind of simplistic thinking, I'm going to try and address it all. I'm going to make the proprioceptive info more salient and usable. I'm going to draw that child's attention to it. I'm going to give that child the practice in doing the kind of motor planning and programming skill that they need to do, in the hopes that with continued practice and giving their brain more time to do it, they'll develop more efficient processing, whether that be developing more synaptic connections or strengthening those synaptic connections. We don't know. Eventually, we'll know all of this, but right now, we don't have good techniques to do that. But we kind of almost do, and another thing I wanted to talk to you about. All right, now we want to differentiate the praxis deficits from execution deficits, because both of these are really motor speech problems that overlap as well. The execution deficits are usually caused by some known impairment in the central or peripheral nervous system. Most often presents as weakness with decreased range of motion, decreased speed, decreased force, etc. I want to make a real quick comment. This isn't one of the neuroanatomy talks, but one of the things that came across my desk most often that I think can be something that's often misunderstood is this idea of low tone meaning weakness. So lots of kids have what we call generalized low tone. And it's usually maybe due to delay myelinization or mild cerebellar difficulties. And typically this resolves. But a lot of kids will have generalized low tone. And so I'll see speech pathology reports saying, well, I'm working on strengthening because they have generalized low tone. And the child comes into me and they're going, ada, aba, adaba, adaba. And I'll look at their therapy notes, and it's all about, the Cheerio and working on, which of course isn't working on strengthening because you need a heavier Cheerio and all that sort of thing. But they are working on strengthening. Well, now and some of you may be sitting there thinking, oh my God, I've done this. You can't worry about this, but I cannot tell you what I didn't know when I started out. And all the patients that I didn't help. I still think about it at night. That's the nature of what we do. I won't go to a doctor under 40 because they come out of medical school, but they have a lot of knowledge, but they don't yet have skill, and they don't have the experience. So if you're new out there, you're not going to feel confident about this till you've been out a while. It's okay. However, I want to really make this point. If you read pediatric neurology notes, they often will say, child presents with generalized low tone, comma, normal strength. Tone is just the partial contraction of muscle fiber at rest. When we move, we recruit motor units. That means you're telling motor strip neurons, go down, innervate the lower motor neuron, to contract more muscle fiber, because that structure doesn't have to maintain muscle tone. Now we've got to actually move the structure. It's a different process. And there are kids with generalized low tone that can recruit enough motor units for a normal movement with normal strength and speed. So here's the practical thing. If a child comes in and goes, ada, aga, even if he sits like this and has generalized low tone, if they're doing that kind of good respiratory support, good laryngeal, gets good phonation, and can do that kind of plosing, you're probably not dealing with strength as an issue related to their speech problem. This is the kind of clinical thinking you want to do. Don't just see a note that says generalized low tone and think, oh, they must be weak. You want to listen to the child, watch the child. And they might have generalized low tone, but that does not mean they're weak. Now, if it's significant low tone, like in a child who has flaccid CP, then they probably do have an execution problem and probably can't recruit enough motor units to contract enough muscle fiber to move a structure with the right range of motion and speed and force. But keep that in mind that it's different. So, what do we mean by motor planning and programming? Why am I going into this so much? Because you have to be able to explain this to students who come and do work with you. You have to be able to explain this to parents. But more importantly, you have to really get it yourself in order to make the right decisions. Sorry, I used the wrong words. The best decisions for the children that you're seeing. So when we talk about motor planning and programming, we want to think about the fact that when we think about speech, speech is just movement that creates noise, so we get an acoustic signal, right? That's what speech is. It's the acoustic kind of way of communicating. So you can generate an airstream, and you generate this subglottal air pressure, and you start constricting that resonating air, and you get shap-a-doo-ga-dee-da-boo. There's your acoustic signal. But that really didn't mean anything, did it, to you? No. So that means that these movements have to occur in a very particular way so that the acoustic output is meaningful to the listener. And when that has to be done a particular way, we know that that means that everything has to reach a certain spatial and temporal target. They have to get to the right place at the right time. Now, if it were discrete, like phonemes or graphemes, that might be pretty easy to think about. But it's not. These movements are continuous. That's why I call them gestures, movement gestures. Remember that movement that's gestural at the level of the syllable has to be in the right place at the right time as it's moving along. That means the jaw has to be in just the right number of millimeters open, with the tongue just forward enough or just high enough or just tense enough to create the acoustic signal we expect in the English language. And all of that has to happen at the same time. And then it's continuously changing. It's complicated, isn't it? So we say that speech production involves this continuous movement of parts of the vocal tracts, and it's continuous at the level of the syllable. We don't stop ever during the production of a syllable in connected speech. So how does the motor planning area do this? Well, as I said, it has to know where things are. Like if I'm going to scratch my nose, my brain, in order to tell my arm what to do, has to know, is my arm up or down? Where is it? Is it still or is it moving already? Is it tight because I'm tense, or is it kind of loose because I'm on vacation? And then it takes all that constant stream of information and continuously, nanosecond by nanosecond, feeds it into my brain, where it's processed in a number of areas and goes to this motor planning area of the brain that then takes that information on an ongoing basis and integrates it all and sends information to motor strip to say, okay, I need just this many motor units to be recruited to go down to the jaw, or for my arm, we're still talking about my arm, to go down to Edythe's bicep so that the forearm moves up, and then her shoulder so that it can go to her nose to scratch her nose. So it's telling just the right number of upper motor neurons to send messages down to the lower motor neurons, to contract just the right number of muscle fibers so I don't hit myself, right? To move to the right place at the right time. Well, that's what happens in speech, only it's happening for like 100 different muscles, with all the respiratory muscles, all the laryngeal muscles, all the oral articulatory muscles, so that the structures of the jaw, lips, tongue, velum all begin to move in the right direction, with the right speed, with the right force, and with just the right amount of muscle contraction to get to the right place at the right time with the right amount of muscle tightening. I have a 2-year-old granddaughter. It's amazing that these kids learn to talk so easily. But we're charged with that small percentage of children for whom that doesn't work so efficiently. And in CAS, we're only talking about 5% of the large group of the speech disordered children that we see. Now that takes out all the children with cleft palate and dysarthria and other major problems, speech sound disorders. 5% of speech sound disorders. And that's our best estimate. And I don't have time to go into all the data where that comes from. So as the child gets ready to talk, particular muscle groups are selected to begin contracting at very specific times so that the structure, the jaw, the lips, the tongue, whatever, usually all of them, will begin to move at a certain time. And we're talking milliseconds here, of course, in a certain direction, at a certain speed, with a certain amount of force and a certain amount of muscle tension, so that those articulators can get to a particular spatial temporal target for the intended continuous movement gesture. With these children that do exhibit severe problems with Praxis, we're not really sure if the primary problem is the actual specification of movement parameters. Now, these movement parameters are just what I've been talking about. Selecting the particular muscle groups so that certain structures will move, and these are the parameters, in the right direction, with the right speed, with the right force, and the right amount of muscle contraction. Those are the parameters of movement. And we're not sure if the primary difficulty is actually in the specification of the movement parameters, either due to the problems in efficient processing of the afferent proprioceptive information, or is it more of a problem in the planning areas of cortex? So we're talking about lots of different things here. We're talking about proprioceptive receptors, and they're different in the face. So sometimes they make choices like tapping and icing and things to stimulate spindle function. And there's really not very many spindles. There are in the jaw, but not in the face. So knowing those kinds of important physiologic things are huge to our making decisions about what might work and not for these children with Praxis problems. But the upshot really is that we can't be sure if the problem is in the proprioceptive receptors, the pathways leading to the motor planning areas of the brain, or those basal ganglia cerebellar circuits that influence movement, or all of the above. So the treatment that we use with kids that have CAS, in my view, should incorporate techniques that make proprioceptive information salient, and I'll talk about how we do that, as well as giving the child practice and doing the planning and programming. So, and this I'm going to say ad nauseum to you all today. So therefore, it's important to think of treating gestural movement transitions versus phonemes. Okay, now a child might have difficulty with Praxis for speech, and for that we use the term childhood apraxia of speech, but they might have problems with Praxis, planning this specification of movement, for non-speech volitional movement. Now, Praxis problems always relate to volitional movement, doing something on purpose with a targeted goal. So in the non-speech, it would be like, show me how you kiss, show me how you blow, show me how you smack your lips, or just have them imitate. Kids with Praxis problems in this context might, instead of blowing, go. They know what you want them to do and they try, but they can't do the actual movement. They can't plan and program the right, so that it happens, so that the right muscle groups are selected and the muscle fibers contracting, so that the right structures move in the right way for the intended target. Now, if, though, that child has actual weakness, then we use the term dysarthria. But we're not going to be talking about that too much today. However, I have to make one point. And this, this is just another example of how hard our job is. There is one type of dysarthria that's not associated with weakness that's common in children, which is ataxic dysarthria, characterized by impaired coordination associated with deficits in the cerebellum. And the problem is that the characteristics of ataxic dysarthria overlap so much with the characteristics of childhood apraxia of speech that sometimes it can be hard to disambiguate them. Now here, the good news is we can, at that level, when the kids are quite severe, we treat it the same way to begin with. So, in this workshop, I guess I took that out. There are ways to disambiguate. Oh, I think that I have this slide later in the assessment thing. There are some things you can think about to disambiguate ataxic dysarthria from the CAS, and we'll get there. So if you just look at this schematic, it kind of helps just show you graphically that when you have these oral motor problems, and I do hate that term because oral motor problems is so general, it doesn't mean anything. Oral problems with the mouth, motor problems with movement. I mean, you could have your jaw wired shut and you'd have an oral motor problem. So you have to really be careful about the use of this term. So we separate them into the execution problems, typically characterized by weakness, range of motion, weakness, which results in decreased range of motion, strength, and speed, or the praxis problem that we've been talking about. If it's an execution problem in the nonverbal context, we have things like drooling and dysphagia. And in the verbal context, we typically use the term dysarthria. If the primary problem is a praxis problem, a problem with planning and specifying movement parameters, in the nonverbal context, we use the term nonverbal oral apraxia. And in the verbal context, we've been using the term childhood apraxia of speech. The problem is that the characteristics of ataxic dysarthria, which are not really due to weakness, overlap this category of CAS. The good news is that we're going to treat ataxic dysarthria and CAS in very similar ways versus the techniques we would use for treating children with dysarthria due to weakness, where we're going to build a physiologic support for speech, whereas in both ataxic dysarthria and in CAS, we're going to use different techniques that relate more to the motor planning and certainly the control of movement as it is ongoing. So in dealing with kids that have severe speech sound disorders, the differential diagnosis is primarily the issue at hand. Our challenge is often to differentiate phonologic impairment from motor speech impairment. And what we're going to be talking about today, of course, is differentiating those characteristics that lead us to use the term childhood apraxia of speech as at least a contributor, if not the major problem, with that child learning or developing good intelligible speech. So I want to make a couple comments, though, about these labels because we've put a lot of emphasis on it. We need them. We do need taxonomies. We have to be able to communicate with each other. It's helpful to have a term that is understood by us as representing a group of speech characteristics. The problem, especially in CAS, is that these categories are not discrete. Kids come with more than one problem almost always. And certainly, if there's a severe problem with CAS, it will affect and influence their development of phonology. So they co-occur, they overlap, they interact each other. And we have to keep that in mind. And we have to consider the use of these terms in the context of this child's developmental trajectory. As kids grow up, as they mature neurologically, there is often improvement in speech just on its own. And then you add therapy on top of that, kids are changing, right? And as they change, the characteristics that you observe, that you see and hear, will change. And at some point with these children that have apraxia, sometimes quickly, sometimes more slowly, those characteristics get to a point where the label apraxia of speech isn't appropriate anymore. Now, this is another point that I included in here because over and over again, I would get children at Mayo who come in and label of CAS. And sometimes these parents usually would travel quite a bit, and so they were fortunate to be able to do that and would often bring the speech pathologist with them. And what I heard the speech pathologist say was, well, I really just, got Johnny, just started working with him, the beginning of the school year. And that's what was on his report, and that's what his previous therapist told me. You never, ever, ever want to do that. It doesn't matter what another therapist thought at another time. You want to write down and talk about what you observe in that child today. This isn't trivial. I heard that. If I heard that once, I heard it 100 times. Probably more in 16 years. Oh, well, that's the diagnosis he came with. You never, ever want to say that. You're a clinician. You make that decision that day for that child in that moment in time, because kids change. And when their characteristics change, they have to have another label, because remember, this is just a label for a speech disorder. And just like something in autism where we use that diagnosis, if they meet certain behavioral characteristics, you got a list of characteristics, and if they have a certain number of them, we feel confident in using that term. It's the same thing. We're going to go over what are those characteristics for CAS that will make us feel confident that that's the best label. Not the only label, but we'll feel confident that that's one of the labels that we might want to use for that child. And as the label changes, then certainly what we do in treatment will change. So how might we recognize these kids that we're here to talk about today? Well, we're just going to make observations, primarily of speech characteristics, but also some non-speech characteristics that are now commonly accepted as being associated with that label. And we have come a long way in feeling more secure about that. And how are we going to do that? Well, we do it through testing, but we also do it through our informal play, building rapport with the child, and I'm going to go through all of that. I will say, though, that in testing, the most important thing that we're going to do is a motor speech exam, no matter what level we're talking about. Even in the nonverbal or very young kids, we're going to create ways to do that. And I'm going to suggest dynamic assessment as being very important. So here's an example of an Apraxia of speech protocol where we start with a language sample. Now, this might be very important in those very young kids. People always ask me, how early can you diagnose CAS? What age are you able to do that? It has nothing to do with age. I have felt very confident in diagnosing children, say at 2, 2.5, if that child is able to attempt direct imitation. All they have to be able to do is to try to say something they don't typically say. And I'll go into this in more detail as to why. So it's not an age. It's when that child can attempt direct imitation of just about anything. So if I have a very young child or a nonverbal child who comes in, I'm going to start, of course, we always want to build rapport anyway, and I'll be playing with the child. And at first, it might just be free play. And during that time, I'm going to be taking a phonetic and phonemic inventory. What phonemes am I hearing? At this point, that's fine. What phonemes am I hearing? Do I hear vowel differentiation? How many vowels do I hear? Are they appropriate? If you know the target, and lots of times you don't, but if you know the target, is it produced accurately? And I'm going to be making observations about, as we all know, we're not going to talk about this because you all know how to do this, about their social communication, their pragmatic communication, how much they can actually convey in terms of communicative intent, and so on and so forth. Today, though, I'll be focusing more on what we listen and watch for if we want to disambiguate CAS. So during this language sample, we're beginning our job, which is to make observations. And right now, we're observing phonemic and phonetic inventories, but also paying attention to any potential characteristics of CAS that we may hear. So what might those be? Well, some of those are red flags, like lack of vowel differentiation. So if the child has only a few phonemes and only a neutral schwa, that's unusual if it's just going to be a phonologic impairment. So that's a red flag and something you would note. If they're a little older or precocious enough, even at 2 or 3, to be able to attempt to name items on something like the Goldman-Fristow or test of phonology. Then you can examine phonologic skill and really make observations about, are there particular processes that you can observe? Are there consistent substitution errors? All the things we typically look for. We're always going to do a structural functional exam in order to determine or rule out dysarthria. Now, here's a problem. You don't want to spend a lot of time on something you don't need to do. So if the child's coming in and you hear a lot of speech sound errors, but you don't see any decreased range of motion, respiration's good, volume's good, phonation's good, you're not going to spend forever just having the child. You never hear any hypernasality. You're not going to take up 5 minutes of this precious time. I don't know how much time you guys get for assessments. If you're in the schools, you're doing it piecemeal, right? Which is unfortunate. That's just not the best way to do it. I tell you, these people that work in the public schools, you just have the hardest job in the world. Thank you. Thank you for doing that hard work. It's really hard. You're not going to spend a lot of time having them go, and do all these things that you already know the answer to. You only do what you have to do to learn something you don't already know. And then the motor speech exam, which I'm going to argue is probably the most important thing we do because it really allows us to make further judgments regarding the presence and the severity of CAS markers, if you will. So let's talk about what those markers are. What are these behavioral observations that we make? First of all, I want to say that a lot of children with a lot of what we say are often present in children who have CAS are also present in kids that have speech delay, and late talkers, even kids that have phonologic impairment. So we can't say that all these characteristics are discriminative. So sometimes they're present, but don't really give us evidence that this is CAS. But they'll be present, probably. And what are these? Well, limited consonant and vowel repertoire. Late talkers have that too, right? Use of simple syllable shapes. Lots of different kids with speech sound disorders have this. Frequent omission of sounds. Frequent in CAS, but you see it in a lot of other disorders, speech sound disorders too. Numerous errors. Poor standard scores and articulation tests. You can get that with any speech sound disorder diagnosis. Poor intelligibility. Any child with a severe speech sound disorder will probably have poor intelligibility. So the rationale, again, what we're thinking about here, children with all types of speech sound disorders can make numerous errors, but we do know that kids with phonologic impairment may make more substitution errors. Now keep in mind, when we say substitution errors, those substitution errors have to be produced with accurate movement. So if the child says tat for cat, there's nothing wrong motorically. They're moving all of the structures of the vocal tract to get to the right place at the right time. It's just the wrong target. But there's no problem there with the movement accuracy. Now, any child with a severe speech sound disorder might also show poor intelligibility, as well as kids that have dysarthria. So that is not discriminative. But here are some characteristics that are more likely to be discriminative. And what I mean by this, there's nothing absolute in our world of speech-language pathology. But what we mean is relatively. They're seen less often in children with other speech-sound disorders. Difficulty moving from one configuration to another, and I'm going to show you that. Movements might be awkward or clumsy as the child attempts this continuous movement across the syllable. Groping, trial and error behavior. You know, people have said over time, you know, I don't understand this groping thing because I don't see groping. And the problem with, and this has been true in adult apraxia too, people have argued this. Well, the trouble is, if you just look at what children can do when they just are talking spontaneously, you're not going to see groping because they're just saying what they can say. That's why the motor speech exam is so important, because when you elicit particular movements that they don't typically use or say, that's when you see the groping behavior. So you're not going to see it typically in spontaneous speech, but you will in a motor speech exam. And I'll show you some examples of groping in just a few moments when we play some tapes. And then the presence of vowel distortions. Think about why this might be the case. If a child has problems planning specific movement to get to the right place at the right time, think about what a vowel is. It's just the configuration of the vocal tract in a certain length and a certain shape. Oh, yeah. That's all we change. But for any particular vowel system, that vocal tract length and shape is very specific. And if the child is planning the range of motion just a millimeter or two off, or the tongue's a little lax or a little too tense or a little too forward, this can be millimeters. And we will hear a distortion. So this makes sense to me that if there's a problem in specifying these movement parameters, even if it's mild, we might hear vowel distortions. So these are common in children that have apraxia of speech and very uncommon in children that have phonologic impairment. So it's somewhat, nothing's perfect, but it's somewhat discriminative. Keep in mind that these vowel errors are not vowel substitutions. They don't say Coke for cake, but they say a distortion that isn't really in the English phonologic system. Prosodic errors, lots of work done looking, and more needs to be done at these prosodic errors. But what the kids with apraxia do typically is segmentation and equal stress, and you'll hear this in some of the videos that I'll show. I'll be showing some extra videos tomorrow where we'll talk in a little more detail about how to deal with these problems. You do also see lexical stress errors, which you'll see in a few moments, but more often it's equal stress and segmentation. Inconsistent voicing errors, this is typically just due to mistiming, and I'm not just talking about assimilative nasality or anything like that, but when you're listening to a child, you might hear, was that a P or a B? You're just not sure. And that happens with these kids because it often falls in that categorical gray area, that gray area of categorical perception. Thinking back to, not many of you, it's a younger group, but those of you that took speech science a long time ago, remember your VO, all that categorical perception stuff for speech perception, where they're just mistimed, and so they're in that gray area. And so we're not sure if we heard, was that pot or bot? I'm not sure. And that's what I just said, likely due to mistiming. So what about ataxic dysarthria? I told you I'd come back to this. We know that ataxic dysarthria is caused by damage to the cerebellum, which helps maintain muscle tone and also works with coordination and balance. So if you have a problem with the cerebellum, you're going to have some inaccurate movements because you're having trouble with this online feedback system, which might cause some inconsistent voicing errors because there's difficulty with coordination. That will lead, of course, to imprecise articulatory contacts. One thing that's different, though, that you don't see as much in apraxia of speech is this incoordination of the respiratory stream. And for kids with significant cerebellar difficulty, kids with near drowning, kids with cerebellar tumors or degeneration of the cerebellum, you see kind of thing where they can't just take a breath and begin speaking at the apex of the respiratory stream and then use the rest of the exhaled air as you speak, which is what we typically do, but rather the airstream is incoordinated relative to the oral articulatory movement. So this kind of differentiates it. But there are other ways to differentiate it as well. Both CAS and ataxic dysarthria are characterized as having inconsistency, and that's true. But let me put it in a little more context. In ataxic dysarthria, they're going to be more consistent across all tasks and in connected speech. For example, if you do a motor speech exam where you go from single words to multisyllabic words, simple words to multisyllabic words to short phrases to long sentences, you'll see inconsistency in both, but that is going to get worse and worse with children that have apraxia as the length and phonetic complexity gets harder. And in ataxic dysarthria, typically it's more stable. Even better is the use of diadochokinesis. I don't test this with every child I see. I only do it when I have to. And disambiguating in ataxic dysarthria is one of those times. So if you take a child with CAS and you say, tell me pa, 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 they might do pretty well. Pa, 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 but it might be slow. Pa, 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 but it'll be fairly regular. Versus a child with ataxic dysarthria who might go pa, 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 where the respiratory stream is incoordinated and they have trouble actually doing it in a nice regular way. Now, CAS kids will have more trouble as you make it more difficult, pada, 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 padaka, padaka, padaka. Whereas the person with ataxic dysarthria is going to have this discoordination in all three contexts. In children that have CAS, we often see global praxis problems. Sometimes it's called global apraxia. Sometimes you'll see neurologists use the term limb apraxia as well as their speech apraxia. Whereas in ataxic dysarthria, they'll have more of an ataxic gait, this wide-standing kind of lurching gait. And you might see intention tremor, where they're having that kind of behavior. You don't see that in apraxia of speech, the atactic gait or the intention tremor. So that's another way to kind of disambiguate. And then, of course, the medical history. If there are kids that have CAS sometimes have cerebellar problems. That's why I'm saying that we're not sure to what degree some of the cerebellar and basal ganglia circuits, both the internal and external circuits, are playing a role here in CAS. But certainly they're probably playing a partial role. And as I said, don't worry too much if this child's nonverbal or very young. At the beginning, you're going to treat these very similarly. All right, the motor speech exam is important because it allows the clinician to observe speech production across utterances that vary systematically in length and phonetic complexity. Now, that alone allows us to make observations that we wouldn't typically make on an artic test or certainly in connected speech. And these observations that we make can allow us to make decisions. Does this child have these characteristics that we think are discriminative of behaviors we associate with the label CAS? So, vowel and consonant distortions, timing errors, dysprosody, segmentation, equal stress, inconsistency across repeated trials, all these things that we've talked about. I want to make the argument, though, that it's important to use dynamic assessment in these motor speech exams. And all this is, and dynamic assessment's been used in language disorders for some time and to a lesser degree in phonologic impairment. It's different than just stimulability testing because what we're doing is really cueing this child in a very systematic way to help maximize their attention and effort toward doing the task, as well as providing cues that might improve their performance. And this is huge in determining severity and prognosis. I don't know how I would talk to a parent, and what do they always want to know? Is my child going to talk? In fact, one year I did a little study on my own, not to publish or anything, but just kept track of questions parents asked me. The most frequent question in that year period of time was, will my child talk by kindergarten? Well, if I didn't do this, I really wouldn't be as confident as I am when I use dynamic assessment. Because you can have two kids who get a 40 on a standard score of 40 on, say, the Goldman-Fristow. But even though they have the same standard score and they're very severe, in your clinical heart, because of your experience, well, maybe some of you, if you're doing your CFY, you may not feel this way yet, and it's okay. It's okay. But if you've seen a few of these kids, you know that one of those kids has a great prognosis and they're going to be out of therapy within, if this is kindergarten, they're going to be done by the end of first grade. Whereas the other child, you're a little worried you might still see this child in junior high. Even though that test does not tell you that. But if you use dynamic assessment, even the people that are still in their CFY are going to feel more confident about talking to the parents about severity and prognosis. Parents out there, how many of you asked your first speech pathologist, will your child talk by kindergarten? Really? Well, that was my data too, so I'm glad to have some confirmation of that. So this dynamic assessment idea just involves a process of cueing to facilitate performance. And when we facilitate performance, we have a better chance of observing kind of this emerging skill. And it contrasts with static assessment, which is what we do in most standardized tests, where the child's well-established skills are measured. And usually after only a single response. What is this? Right? I think that dynamic assessment really also offers a particular advantage when we're trying to disambiguate kids with motor speech impairment. It allows us to observe what the child does when he or she attempts particular movement gestures for specific syllable shapes that he or she doesn't do habitually, that isn't part of their spontaneous speech. And that allows you to make additional observations, such as groping, that wouldn't be possible in other situations. And we know when a child's trying to imitate particular things, we see increased attention or effort toward this particular goal, even with minimal cueing sometimes, because of just that little bit of extra support. For example, if I'm doing a motor speech exam, I might say, okay, watch me. I want you to say it after me. And if you have trouble, I'll help you. And I might say, tell me, bunny, bunny. And they try, and if they can't do it, I provide whatever cueing is most appropriate. We'll go over, in treatment, we're going to go over a cueing hierarchy that works just as well here. And with that, just that, sometimes it's just as easy as saying, no, watch me again. Let's try it again. I'll help you. Get your lips together. Bunny. And just that little bit of cueing, drawing their attention to my face, maybe it's just a gestural cue, allows them to put more attention and effort toward what they're doing. And I can see the behaviors I need to see to make decisions. Does this kind of jive with this list that we use as being discriminative of having at least some problem with CAS or not? So it can be very helpful. So I've already talked about that. So besides, as I said, this differentiating whether or not there is a praxis impairment as part of the problem, it's also important to really determining severity. And this is extremely important because if a child needs a whole bunch of cueing to get even a little bit of change closer to the goal, we know that problem is much more severe. But the reason this is important is that as I talk about the principles of motor learning in a little bit, I'm going to be saying how one of these principles will be, do I use block practice or random practice? And in kids with this level of severity, it's not going to be either. It's going to be somewhere along that continuum. And how do you make that decision? And that decision is often guided by the severity of the problem. So determining severity is very important to your treatment decisions, especially in the sense of how much and how we might implement these principles of motor learning. Frequency and type of feedback. Other principles of motor learning we'll discuss are also influenced, not just by the age of the patient, but by the severity. So dynamic assessment also helps our treatment planning. The types of cueing, for example, that proved helpful during the motor speech exam are likely to be useful in therapy. But more importantly is later I'll be talking about how important it is, these decisions you make about initial stimuli. We don't think about this in the same way with phonologic impairment at all. And we have less practice in thinking about stimuli with respect to these kids that have praxis problems. So we will spend some time on that. But by reviewing the patterns of errors on the motor speech exam, especially errors, vowel distortions that are noted, and particular syllable shapes that are easy versus difficult for the child, really facilitates the initial choices of our stimulus sets. So one motor speech exam, and I put this in your handout, but we're not going over it in any detail, is this DEMS, and it's ridiculous that I'm talking about it, except that it will come out, because it's not out. It's published by Brooks, so you could, and it's just going to be, it's very, very, I've talked them into keeping this very low cost. We wanted to just make it free in a journal, but it just didn't work out that way, because it's too complicated. The manual's kind of big. So the only reason I'm talking about this is that I'm going to get to the point where I say you don't need the DEMS. So, however, this dynamic assessment, a motor speech assessment for kids, I started doing this just naturally because I knew I needed something different for very severe children, these nonverbal kids that were coming in the clinic every day, where I would be trying to do these motor speech exams. And I wanted to create something a little more structured that would allow me to do the kind of cueing that I needed. So I developed this hierarchy of cueing. And also, we wanted eventually to have a tool that really had some validity data, that is, some data to show that if you do this motor speech exam in this way, there's a good probability that you'll correctly disambiguate those kids that have significant problems with Praxis and kids that don't. And that was published 2-3 years ago now, and I still don't have the training tape done. So what we did was we just have this hierarchical list like any motor speech exam. But for each utterance, we're making observations about overall movement accuracy, about the vowel accuracy, about consistency, and about prosody. So we're taking those characteristics of CAS that are most commonly accepted for this time, and then use a multidimensional scoring system to look at their responses to different levels of cueing. But you can devise a dynamic motor speech exam for a particular child by just choosing a hierarchy of syllable shapes, choosing very particular consonant vowels depending on that child in front of you. If it's a nonverbal child, you might start with something as simple as a CV, like hi, bye, no, and some VCs, up, eat, on, and then go to CVC that's easy, like mom, pop, peep, where you're varying the vowel a little bit, and then CVCs that have the first and last phoneme different, etc. And then you get to reduplicated syllables, papa, mama, BB, and then on to bisyllables that are more difficult, bunny, movie, whatever level your child's on. Have the child repeat the utterance, provide cueing as necessary using your own clinical skill. And you can choose your own scoring thing. We use binary for prosody and consistency, but multidimensional for the vowels and for the overall accuracy. Then you make these observations for each of the utterances in whichever way you want. And that would be absolutely fine, because you're meeting what I think is important conceptually by eliciting particular behaviors that are somewhat hierarchically organized, looking at their responses to cueing to see if they improve given those cues. And when we talk about treatment this afternoon, those kind of cueing techniques are exactly fine to use in this context. Now, there are other observations you may want to make as well. Larry Schreiberg, who's probably done more programmatic work at really looking for diagnostic markers of CAS as well as other speech sound disorders, coming up with a nice taxonomy, came to me at Mayo to say, you know, there's this thing called, I have such word retrieval problems lately. It's a computer term. Where, I'll think of it. I'll come back to this. Where if you've seen a whole lot of kids and you see the same kind of things, pattern recognition. It's about pattern recognition. So Joe and I both had over 40 years experience, and we're working full-time clinically, mostly with neurologic patients. So we've seen a lot of this day after day after day. So he said, well, what are the 10 characteristics you would see most often in the people you end up labeling as apraxic? And so we gave him this list, and then he had me listen to all these tapes for a lot of his different research papers, and he called it the Mayo 10, which there's no such thing. But you see this in his papers. And this is what we came up with. So you can't, in a multidimensional scoring system, look for all these characteristics. So we chose those that seem most discriminative. And then at the end in the score sheet, and you can do this too, we just have, well, we have this list on every page of the form where you can just tally them. Just put a check mark. You heard it in that CV context, or you heard it in that VC context, or you heard it in that multisyllable context. And then you look at them and see, well, throughout the test, did you also notice some of these other behaviors? Just gives you increased confidence that, maybe there is a problem with Praxis that's contributing to this child's speech sound disorders. So those are some of the papers that we've used this for. So that's kind of the brief overview of assessment. That's all we have time to do in this one-day format. But basically, we're going to use the interpretation of our assessment results, not just to come to our differential diagnosis, which is the most important thing, but also to write those initial diagnostic statements which reflect our clinical thinking. And I'm going to talk about why I think this is so important. And then to make our initial recommendations, as well as to determine those very important initial therapy goals. We make initial clinical decisions. Remember, I talked about how these clinical decisions are the important thing, regarding what approach we're going to use, what method we're going to use, and our initial stimulus set. We'll talk about that later today and at more length tomorrow. And then we'll use the principles of motor learning to determine, number one, how are we going to organize practice, and two, how are we going to provide the type and amount of feedback, and third, how are we going to, and what kind of cueing strategies will we use. So let's talk for a moment about diagnostic statements. Now, when I read IEPs, I don't really ever see what I would recognize as a diagnostic statement. If you work in a clinic or a hospital, you're more likely to see it because, again, in the public schools, you don't really have the paperwork that lends itself to writing these diagnostic statements. But even in clinics and hospitals, it's not usually a diagnostic statement like I got used to writing at Mayo. So we're going to talk about that for a few minutes because practice in writing them gives us practice in clinical thinking, and being thoughtful about your diagnostic statement really leads you to the most appropriate treatment planning, at least in my view. I think they need to reflect the clinical thinking that went into this diagnostic statement. And it should, in my view, illustrate the overlapping nature of the presenting deficits, as well as to include at least some statement of the severity and prognosis. We don't have time to practice writing them today, but I want to go over at least one or two. Yeah, I'll go over a couple. So the first one, and I just took these from my reports at Mayo. This also allows, if you're seeing a child and you want to go over a very succinct statement with the parent, make sure you explain it, every bit of it very clearly, you can use this rather than the whole report. It's also something you can send to a physician and say, oh, just read the diagnostic statement, because they're not going to read your whole report. But if you're succinct yet complete in your diagnostic statement, the referring physician will learn a lot about what clinical thinking went into this. So this child's severe delay in speech acquisition is due primarily to deficits in motor planning programming skill, parentheses, childhood apraxia of speech. I usually put it that way to help the reader understand the nature of the impairment, not just the label. Characteristics include, and then I'll usually write what those were: inaccurate movement trajectories leading to consonant and particularly vowel distortions, groping for articulatory configurations, inconsistent voicing errors, segmentation at all attempts at bisyllabic words, and inconsistency across repeated attempts. He also exhibits a significant delay in phonologic skill and a severe deficit in expressive language. Receptive language is in the low average range. There is no evidence of cognitive impairment, social or pragmatic language deficits, or dysarthria. So in that one statement, I try to impart what the primary speech diagnosis is, but as well as the other speech diagnoses that are appropriate. And I also try to make a statement about how severe it is. And then you also want to point out, well, what is working quite well here? That's important for people to know as well. Receptive language was low average, but normal. Low average is normal. No dysarthria. Socially, pragmatically, child's doing great. It's important to put all of that into a diagnostic statement. Okay, this is another scenario that might even be more common. This child exhibits a severe phonologic impairment characterized by the processes of fronting, final consonant deletion, and stopping. She exhibits numerous consistent substitution errors, for example. There is no evidence of childhood apraxia of speech or dysarthria. In particular, she demonstrates no consonant or vowel distortions. She has normal phonation, normal speech rate, normal prosody, as well as accurate articulatory movement gestures. Receptive and expressive language scores are in the low average range. No cognitive or pragmatic language deficits were noted. Now, this was a child that had come to me with a diagnosis of apraxia of speech due probably to her severe unintelligibility. This child exhibits a moderate phonologic impairment characterized by fronting and consistent typical substitution errors for later developing sounds. In addition, he exhibits a slightly slower rate, more difficulty with multisyllabic words, occasional segmentation, and very occasional vowel distortions, providing evidence for a mild contribution of difficulty with praxis for speech, mild CAS. There's no evidence for dysarthria, no evidence for receptive or expressive language delay, or cognitive impairment. So that gives you an example of how these kids don't come with one label. They don't come in a box. But in your diagnostic statement, you kind of use all your clinical thinking to put together the pieces of evidence that you accumulated during your assessment tasks to clearly delineate what's the primary speech diagnosis, what other speech diagnoses play a part in this, and what is working okay. And then that's going to build your argument really for the recommendations that follow. Let's move on then to, before we talk about principles of motor learning, I want you to listen to this child, and I want you to think about a diagnostic statement. Now, you don't have all the language results. She's low average, receptive, and expressive language. There's no real cognitive impairment. There's no pragmatic language deficit. She's not on the spectrum, any of that kind of stuff. But I want you to just think about the beginning of your diagnostic statement when you talk about speech diagnoses. You're going to see her doing part of the Goldman-Fristow, and you'll hear some spontaneous speech. So what I'd like you to do is just make some notes about the characteristics you hear and whether you would think they provide some evidence for phonologic impairment, evidence for childhood apraxia of speech or difficulty with praxis, or evidence for dysarthria. Just put those in your three categories. Even though it's not that black and white usually, give it your best thought, your best shot.
Say this one.
Three.
Okay.
Go home.
Good job.
Up. Night. Boom. Yeah, bit boon and little boon and bit hot and little hot.
The spoon's a big one, but what's this one?
Got
She said big hort and little hort.
A cup, but what did you say? A big?
a big boon and a little boon and a bit fork and a big and a little fork.
Are these forks or knife? What's that?
Sable.
Okay. Who's that?
Monkey. Banana. Tree.
Good. Okay.
Zipper. Zipper.
Okay. Say it one time.
Zipper.
Whoa, you're thinking about your sounds.
Fiddle.
Okay.
Duck.
What color?
Yellow.
What's a duck say?
Quack. Quack.
Good job. What's that thing?
Creeper.
A sweeper?
Yeah, we have a little one and a big one. But we
Oh.
just bought a red one.
You just bought a red one?
Yeah, and we just gave the new red one. We good.
You could do what?
We took a date on new one what he not like he believed they did be good.
Oh, okay.
Swimming.
She's swimming. Good
I
job.
want to swim in the outside bowl.
You want to swim in the what?
Okay, so let me hear some of your characteristics. Who wants to share what they wrote down? Yes, thank you. Loudly, and I'll repeat. Okay, so some inconsistency. Very good. She was inconsistent over repeated trials. Oh, you heard voicing for unvoiced. What was that context? I didn't hear that one. Okay. I didn't hear that, but I believe you. What else? What'd you write down? Look at your sheet. Let's go. Yes. Sorry? Oh, cluster reduction, right? Yes? Her speech intelligibility decreased as she went into spontaneous speech from single words. Yes?
I saw some articulatory gestures before anything came out. So they were, there was some groping, I guess is what you would call it, but it looked like she was kind of trying to program it and then say something.
Okay. What else? Yeah. She had lots of omissions. All right. This is one of those children that fooled the clinician, because when she came to Mayo and we did the whole assessment, and you don't have the luxury of having the whole assessment, but she is a phonologically impaired kid, and there was no evidence of apraxia of speech. And the reason I wanted to show this is some of those things, especially the inconsistency, can be seen in other kids. But if the movement patterns are all accurate, we can't really say she has a motor planning problem. So they need a little fence up here. And I'm going to play this again from the beginning, and we'll look. I want you, when we reach that part like that you thought was groping, let's talk about it and see if it really was groping. The other thing is that all of us grope once in a while, and kids with phonologic impairment might grope here and there. But it's not a kind of characteristic that you see at all throughout. So if you notice something once or twice, it's probably not a piece of data that you put into your clinical thinking about your differential diagnosis. Yeah? They were accurate. Her prosody was beautiful and perfect. Her rate was perfect. Her substitution errors showed good movement accuracy. So let's go back to the beginning.
This is a child who does not have childhood apraxia. Her speech sound errors are quite predictable. We call these phonologic errors. She doesn't have inaccurate movements, but is simply using the wrong sounds. Examples from this clip are nipe instead of knife, poon instead of spoon, and outtide pool for outside pool. Note that she is starting to correct her errors. Her vowels, speech rate, melody, and stress patterns are all quite good. This type of speech sound disorder is much more common than childhood apraxia of speech.
House.
What's this?
Window.
What's that?
So if all you heard was house, you might think that's a vowel distortion, and she held it a lot longer. And we say kids and adults with apraxia of speech hold that longer. Well, she's not really happy to be there. You can see that on her face, and she's just doing an affective thing. I mean, kids do that. And so we say, nope, use your big girl voice, let's go, and we reinforce her normal talking. You never hear that again. So don't take one piece of data, and if you're just doing your CFY, you may not recognize that that's just affective. But when this pattern recognition thing is real. When you see lots and lots of kids, you'll see that now and then fairly frequently, and then you'll recognize it. Oh, that's not a piece of data that is pertinent to my differential diagnosis.
tree.
Okay, let's put him on the side. He's making noise, we can't hear you.
That's my colleague,
Say
Ruth
this
Steckel.
one again for me.
Telephone.
Say this one.
Tree.
Okay.
Telephone. Good prosody, correct vowel, accurate vowels, normal rate. She's just substituting that glottal fricative for the F. Telephone.
Telephone.
Good job.
Gap. Night. Boon. Yeah, bit boon and little boon and bit heart and little heart.
The spoon's a big one, but what's this one?
Cup.
A cup, but what did you say? A big?
A big boon and a little boon and a bit fork and a big and a little fork.
There's the inconsistency. Why do you think that happened? Because she's in therapy and she's working on it. When she put her attention to it, she could do it. So here's the problem with this consistency thing. And in the ASHA position statement where they talked about consistency being one of the important things, it really is one of the important things. But it's usually consistency over repeated trials. And the other issue that plays into this is severity. So if you have a child with very severe apraxia of speech, they can't do very much, they're going to be more consistent. If you have a child with phonologic impairment who's in treatment, as they're developing that phoneme or suppressing that process, they're going to start being more inconsistent. So you have to put this idea of consistency in the context of both severity and where they are in therapy. Some apraxic kids will be very consistent if they're very severe. Some phono kids will be inconsistent within each targeted sound as they start mastering the sound. Yeah? There's somebody that knows the literature. I love it. The question was, is there a category of impairment that is called inconsistency? And indeed, Barbara Dodd has a whole classification system in which one of her categories is inconsistency. And I think that we do see kids who are quite inconsistent. Sometimes it's maybe just due to they don't pay as much attention, and when they're not paying attention, they're more inconsistent. For our purposes today, however, I think we want to think about consistency as it relates to differentiating kids with CAS. And all I'm telling you is that in my experience, we have to be very careful about noting why the inconsistency occurs, or in the case of CAS, why they might be consistent. It's just because they're quite severe and can't do much. But why some phono kids might be inconsistent. The thing to look for is the movement always accurate, even if the target sound that they're going for is different. It's a substitution. If the movement is accurate, so if they're stopping or fronting, but the movement to that t versus k is accurate, then it's not a praxis problem. So consistency has to be interpreted. This is the whole thing about clinical thinking. You have to interpret these things based on severity and where the child is in therapy. I love it when people read the literature. This is so good. Okay, so we got a good sense of that. So that's a child with phonologic impairment. Why do you think she had the diagnosis of apraxia of speech from her therapist? Primarily, it was her unintelligibility, because in spontaneous speech, she was always kind of, and this is another one who's like a fast talker. She's just developed that. It gets her through it. You know, it's her personality, and she just goes for it. Other kids that are hard to understand kind of hold back or put their head down or don't talk as much. So it just depends. Like, she's a go-for-it girl. So let's look now at a couple kids with dysarthria, just to differentiate that from, oh, dear God, I hate this, from apraxia of speech.
Distortion of sounds that likely reflect weakness. He also has some spasticity that we hear as strain in his voice and his slow rate of speech. His comprehension and intelligence, however, are quite good.
I live in a blue house. She has a big chest. The chick has a broken leg. Don't go too near to the water.
So you can see the difference. So he's a child for whom you might want to build that respiratory support. He is even tied into this wheelchair because he has such weak truncal strength. And indeed, we worked on building physiologic support for increased tidal volume, increased subglottal air pressure. And with dysarthria, and this is a whole different workshop, you know, you want to determine what they can do versus what you can get them to do with maximum cueing and practice. And for him, we were able to make some real changes, never, of course, within the typical range, but improvement. So that was really nice. We would not use the techniques I'll be talking about this afternoon, though, with a child like this. In this case, we're going to work to build physiologic support. Let's look at some tapes first of different levels of severity, and then we'll show these kids in some therapy.
Following examples are from evaluations and are not examples of therapy. This clip shows word repetition during an evaluation. Again, we're not providing therapy here, but just examining speech characteristics as he tries to repeat. Notice the inaccurate movements resulting in sound distortions. Good job. Bye. Up.
Up.
Moo. Dad.
Dad.
Home.
Up.
Out.
Up.
Out.
Out.
In this next clip, you see the child repeating words he has been practicing in therapy. These are called probes, which are done periodically to evaluate progress. We don't help the child during probe testing. Here you will hear some vowel distortions, slow rate of speech, and see inaccurate movements. Knee.
Me.
No.
No.
Hi.
I.
You should practice.
Probe testing, you never cue or help the child. It's a problem. Every time I do probe testing, I start doing therapy. Don't do that. Don't do that.
Hi.
Good. Mom.
Mom.
Me.
Me.
My.
Bye.
Hi, Mom.
Hi. Mom.
My knee.
Not me.
Oh, no.
No. Oh no.
Good.
So that shows you the conscious effort that he has to put into it. Could you appreciate there was a very subtle distortion when he said me, where the M was in between a plosive and a nasal. That's kind of a common apractic type of distortion that you don't hear in kids whose primary problem is phonology, but it's subtle. I have a little bit of a pet peeve that in our training programs, we don't do any, very seldom do programs have their students in speech pathology do a lot of listening labs. Whereas in the medical school, cardiologists listen for hours to heart murmurs to be able to differentiate them. Our neurology residents would listen to EMG signals for hours because they're diagnostic. Our whole profession is based on perceptual assessment, and we don't do that. By and large, most classes, whether it's a phonology class, a motor speech class, a class in cleft palate or stuttering, whatever, all of them should have listening labs. And we don't do that. So I don't feel bad when you're not sure. So I want to point out some of these. And believe me, I was in the universities for a long time. I take as much credit for that. Part of it is we just have too much to teach in a short period of time. He's also making some mild vowel distortions, but when you know what the target is, you may not really appreciate them as much as we should.
O, E, O,
job. In this next clip, you will see a child who exhibits a number of characteristics of childhood apraxia, including groping for sound positions and off-target movements that distort sounds. Notice how he is inconsistent over repeated tries at the same word. Toward the end of the clip, notice how he does better if he's looking at the clinician's face.
Hi.
This is a very, very old tape. This young man is like in his 20s now. But I continue, that's Joe Duffy, you hear. He's working with the child. This is just a sample of his speech, so it's just him repeating some words. This is classic apraxia of speech. He has every characteristic. But the other reason I like to show it is, what else do you notice about this child? He's got bilateral hearing aids. He's hearing impaired. He's low cognitively. He's got language problems. He's got very little speech, so we really don't know what his phonologic system is like, but it's certainly quite delayed, probably because of the severity of his motor speech problem. So I play this tape because this is the common kind of child with severe apraxia that we would see. They don't come with just one problem. But he's also a great one to use for teaching because we can really point out all these apraxic characteristics. And I'll stop it now and then and point out a few things.
Papa.
Papa. That's a lexical stress error. He puts the stress on the wrong syllable. Papa. In a bit, you're going to see children that do more slower rate and segmentation, which is more common of apraxia. Groping.
2 day.
So a lot of people talk about, they use the word jaw grating. Well, what that really means is specifying how far the jaw should open, or planning, doing the movement specification. And kids will, by and large, always be too big because they're trying hard. And so they make it bigger. So that's a motor planning problem.
Dad.
Da.
Very good. No.
Mo.
No.
Mo.
Nana.
Up.
Groping.
Key.
Mm.
Go.
Up.
Now say I. What's this? I. Say ow.
Up.
Ow. Up.
Pa.
Up.
Pa.
Up.
Up.
There you go. Very good. Say it again.
Pa. Pa.
Look at me. Say up. There you go. Do it again.
Each time he was successful, he had watched Joe do the model. This is something that is so facilitative that you really, I talk about these take-home things, but if you really get rid of the extraneous stuff and just have them watch you, the children that are apraxic, you'll see that it's much more efficient than when you go through pictures.
Up.
Do it again.
Pa.
Do it again. All right. Who's that right there?
In this next clip, you will see more probe testing where we are looking at the child's ability to say the phrases on which he has been working. Notice his deliberate manner of speaking, his slower rate, and the concentration he needs to use. He will need to use less concentration as the movement accuracy becomes more automatic with continued practice.
I sit on, whose turn? My turn. I sit on my bed.
I sit on my bed.
Bed. I need my Ben 10.
I need my Ben 10.
Oh, I heard all those good sounds. I won't fight.
I won't write.
Good job. Look at me over here.
That was the parents' request.
I will have fun.
will have fun.
Let's try that again. Watch Edie.
I will
I will have fun.
have fun.
How about this one? I write with my pen.
I write with my pen.
So as you can see, we were loading his stimulus set with eh and I. Those actually are very, very hard for apraxic kids because the vocal tract shape has to be so specific. So those are probably the hardest vowels to work on. So here's an example of a child that has phonologic impairment with more mild, some people would say mild to moderate CAS.
In this clip, you will see the child naming some pictures and talking with the clinician. Note that he has some typical developmental sound errors, such as substituting T for K and D for G, as well as difficulty with the R sound. We call these phonologic errors, and they are not associated with difficulty with movement planning. These errors are consistent in that he always does them the same way. However, he also exhibits some sound distortions and slower and more deliberate speech, which is often seen in children with childhood apraxia. Many children with apraxia also make developmental or phonologic errors.
Hey, can you tell me what these are? What is this?
A house.
Good job. What's this part of the house?
A roof.
This is the roof, and this is, you look out the
Window.
Good job. What's this?
A tree.
Good job. What's this?
A phone.
What's the long name for it? Is it a telephone?
Yup.
Can you tell me that?
Telephone.
Good job. This is a
Teacup.
teacup. That's right. It is a teacup.
I have some yuckies in my ear.
You have some yuckies in your ear? What happened?
Doctor had it. I was playing in the swimming pool last night.
You were playing in the swimming pool last night.
Yup. And Daddy hit my foot.
So here's an interesting kind of practice in clinical thinking and interpretation. So what was all that pausing about? Wasn't motor planning. He's also language impaired. So he's looking for words and trying to get the syntax right. That's what that was about. And when he kind of figured that out, he goes ahead and he just produces it, but you hear a lot of vowel distortions and some elongated vowels. But you want to be able to differentiate, you know, what are those pauses really about? Are they word finding? Are they pauses for syntactic encoding? Or are they really pauses for more motor planning?
Did you hit your foot?
No.
What is?
Dalton.
Oh, Dalton. Is that your brother?
Yeah.
Yeah, Dalton hit your foot. Well, tell me what you were doing.
Playing on the blue slide.
Oh, playing on the blue slide. What was this?
A teacup.
A cup. Good. What's this one?
A knife.
And this is a...
Spoon.
Good job. What is this?
We put sand in it.
A wagon. You put sand in it. Can you say?
Can you hear the vowel distortion? Both in wagon and in sand. But he distorts them differently in each word. Common in CAS. Because of the co-articulatory influence.
Wagon with sand. With the
What's
sand.
this?
We put sand in it.
That's right.
We need a wagon. We need sand.
Mm-hmm.
So that was a child with more mild CAS. Now he has the characteristics that are clearly evident in most of his utterances, but I call that more mild compared to many of the kids I see who have almost no speech. When we did his whole testing, he came out with I think his standard scores on both receptive and expressive language were like 77. Both, they were the same, I remember. So he had a moderate language impairment, both receptive and expressive. He had severe phonologic problems, processes you could identify that were consistent. But at the same time, he also has this problems with apraxia of speech, in that he has numerous vowel distortions and some slow and some kind of segmented speech. He sounds quite stilted, doesn't he? Yeah, he's just not natural sounding at all.